Good morning, everyone. Today we are having a debate. The topic is metastatic germ-cell tumor good risk category based on IGCCC G risk stratification, and it is between 3 cycles of BEP versus 4 cycles of PP in good risk category metastatic germ-cell tumor. So Rahul will be having a talk on 4 cycles EP, and against Rahul there will be a Pritesh who will talk on 3 cycles BEP. So Rahul, you can start sharing.
So Pritesh here. I'll start first.
Yes, Pritesh, you start first.
Okay. So good morning, everyone. I'll be speaking for 3 cycles of BEP. I'm audible, sir? Yeah.
Yes, Pritesh.
Okay. So, so we'll discuss about what we already know about testicular germ cell tumors, what we want while treating germ cell tumors, what are the different trials, and how to choose between 3 cycles of BEP versus 4 cycles of EP. So, testicular germ cell cancer are the most malignancies affecting adults between 15 to 35 years of age. They have a high cure rate of around 90 to 95%. Updated IGCCG survival updates have shown that the good risk survival of 5 years is around 96%. Those of intermediate risk is about 89%, and poor risk is 67%. Just a brief summary about the division between good prognosis, intermediate prognosis, and poor prognosis in non-seminomas and seminomas. So in non-seminomas, good prognosis are testicular or retroperitoneal primary, no non-pulmonary visceral mets, and all the tumor markers between good range. AFP less than 1000, beta HCG less than 5000, and LDH less than 1.5 times the upper limit of normal. For seminoma, any primary site, no non-pulmonary visceral mets, and normal AFB, and any HCG and any LDH can be included in good prognosis. Whereas for intermediate prognosis, testicular or retroperitoneal primary in cases of non-seminomas, no non-pulmonary visceral mets, and tumor markers in intermediate risk, any one of either AFP between 1000 and 10,000, beta HCG between 5,000 and 50,000, and LDH between 1.5 to 10 times the upper limit of normal. For seminoma, intermediate risk includes any primary sites, and no non-pulmonary visceral mets, and normal AFP, any HCG, and LDH. For poor prognosis, for non-seminoma, mediastinal primary or visceral mets, or poor tumor markers like AFP more than 10,000, beta HCG more than 50,000, or LDH more than 10 times the upper limit of normal, and seminomas don't have a poor risk. So when we know that the germ cells have response rates of around 95 to 96% and 5-year survival of around 90%, what do we want while treating them? Of course, while choosing a regimen, the cure rate should be good. The toxicities, both acute and long-term, should be as less as possible. Minimum long-term morbidity is something which we require. Quality of life should not be hampered, and they should, of course, be cost-effective. I think this is what we need while treating any malignancies. So this is just a brief algorithm for treatment of metastatic germ cell tumors. For good risk seminoma and for non-seminoma good risk germ cell tumors, both what is approved is 3 cycles of BP or 4 cycles of EP both. There is no preference to any one of the cycles given as per the recommendations. So how did BEP as a chemotherapy come into picture? So prior to development of Cisplatin for the treatment of germ cell tumors, dactinomycin, chlorambucil, methotrexate were used in various combinations with the response rates of very less of around 50% and 10 to 20% of complete response rates. And however, the cure, long-term cure was only 5 to 10%. After the development of Cisplatin, the cure rates and the response rates have improved drastically. So one of the first combination chemo regimens which was used is Cisplatin, Vinblastine, and Bleomycin. And Einhorn et al. In 1974 presented a study in which the CR rates was 74% and partial response rates were 26%. 85% of the patients were disease-free at 5 years, and 57% of the patients were disease-free till 13 years of follow-up. So after that, another study was done by Einhorn et al. And the group itself, for which 45 patients who did not respond to PVP, as in Cisplatin, Vinblastine, and Bleomycin, they were given Cisplatin and Etoposide. And what they saw was there was 43% of the patients, that is 19 patients, achieved complete remissions using this form of salvage chemotherapy. So this high rate of responses in salvage setting made them give an indication of using Etoposide in the first line of management of germ-cell tumors. So there was a randomized controlled trial done by Williams et al. Which compared Cisplatin, Vinblastine, and Bleomycin versus Bleomycin, Etoposide, and Cisplatin. And what they found was in 261 patients, which were randomized into two groups, the response rates of BEP was 83% versus 74% in the Vinblastine group, which was significant. And high number of patients, around 77% of the patients were disease-free at 5 years as compared to 61% patients in the PVP group. The survival was, of course, higher of BEP, and the myelosuppression and pulmonary toxicity were same in both the groups. And neuromuscular complications, which are one of the most limiting complications for the Vinblastine group, were much less in the BEP group as compared to PVP group. So what they concluded was Etoposide with Cisplatin and Bleomycin is superior to Vinblastine and Cisplatin Bleomycin in the treatment of germ cell tumors. And so BEP came into the play. So this is just the side effects of the study, and the severe neuromuscular complications, as we can see, was less in the BEP group as compared to the PVP group, that is the Vinblastine group. So after BEP came into a picture, there was a discussion for whether to give 3 cycles or 4 cycles. So this study done by Saxman et al. Compared 3 cycles of BEP versus 4 cycles of BEP in a randomized controlled trial, and they have given a data of around 10 years after 10 years of follow-up. They had 184 patients, and both patients were both seminoma, non-seminoma histology. And overall disease-free survival was identical of around 92% in both arms. And at a follow-up of median follow-up of 10.1 years, survival analysis did not show any difference between the 2 treatment arms in terms of overall survival as well as disease-free survival. And toxicity profile was, of course, better with 3 cycles because you are giving less chemo as compared to 4 cycles. And hence they concluded that 3 cycles is sufficient to treat good risk germ cell tumors. This was another study which compared 3 cycles of BEP with 4 cycles of chemo, in which 3 cycles were BEP and 1 cycle was EP. And they also compared 3-day schedule of chemotherapy with 5-day schedule of chemotherapy. And around 812 patients were randomly assigned to receive either 3 BEP or 3 cycles of BEP and 1 cycle of EP. And of these, 681 were randomly assigned to give a 5-day chemo versus 3-day chemo. So the doses were same. Etoposide was given at 500 mg per meter square. So for 5-day, it was 100 mg per meter square for 5 days. And for 3-day, it was 165 milligram per meter square for day 1, day 2, day 3. And Cisplatin 20 mg per meter square for 5-day and 50 mg per meter square day 1, day 2 in 3-day cycle. What they also tried to evaluate was the quality of life. So the primary endpoint for this study was duration of PFS, and the secondary endpoint was overall survival and the quality of life. What they found out was the 2-year PFS was 90.4% in 3 cycles of BEP and 89.4% on 3 cycles of BEP and 1 cycle of EP. So 3 cycles is sufficient for us to give. And quality of life was better in patients receiving 3 cycles of chemotherapy as compared to 4 cycles, and 5-day of treatment was better as compared to 3 cycles. What they've postulated is because 3 cycles had to be given more doses in a less span, they had slightly more paresthesias, anorexias, and other common side effects, and hence quality of life was better in 5 days of treatment of the chemo BEP. So what is more problematic for patients who are treated with Bleomycin, Etoposide, and Cisplatin is there is pulmonary toxicity. Around 10% of the patients have some clinically significant pulmonary toxicity, and which can be fatal in around 1 to 2% of the patients. there is increase in the Raynaud's phenomenon, and skin toxicity and neurotoxicity is more, around 4 to 5% in bleomycin. That with etoposide is myelosuppression is one of the most common side effects, and leukemic potential of etoposide, which is cumulative. As the dose of etoposide increases from 1000 milligram per meter square in chemo, the risk of leukemia increases, and if you give more than 2 grams, it is there is around a 20-fold increase in the leukemia risk as compared to 1.5 or 1 gram of etoposide. For cisplatin, ototoxicity, nephrotoxicity are more, and it also depends on the cumulative dose of the cisplatin. So what they tried to do is they tried to remove one chemotherapy of the 3 and tried to see what are the response rates. So etoposide was brought from second line to first line, so it of course has a good response rate. Cisplatin has improved the response rates from around 50% to 80 to 90. So that also is an important integral part of the chemo regimen. So third, which they tried to reduce, was bleomycin. So they tried to do studies in which bleomycin could be omitted from chemo cycles. So this was one of the studies done by Lohrer et al. And they tried comparing 171 patients who were randomly assigned into 3 cycles of BEP versus 3 cycles of EP. And what they found was the disease-free status at the end of treatment was 94% in BEP risk group and 88% in EP group, which was not statistically significant. However, greater number of treatment failures, including persistent carcinoma in post-chemotherapy resected residual disease and relapses, were more in the EP group as compared to BEP group. And the failure-free rate and the overall survival was better in BEP arm as compared to EP arm. So, and also the toxicities were comparable in 2 arm in this study, and there was no clinical significant incidence of pulmonary toxicity with BEP. So in this study, they concluded that 3 BEP is better than 3 EP, and bleomycin cannot be omitted. This was another study which compared 4 cycles of BEP versus 4 cycles of EP. And what they found was, in this study, the dose of etoposide was 120 mg per meter square. That is less for day 1, day 2, day 3. So total dose of etoposide was given 360 mg in each cycle as compared to 500 what we give in normal dose BEP. And they compared the complete response rate at the end of treatment, and they found that the complete response rates of BEP 4 cycles was better as compared to 4 cycles of EP, which was 95% versus 87%, which was clinically significant. And on a median follow-up of 7.3 years, 4% patients on each group had relapsed. So 4 cycles of EP is better than 4 cycles of BEP is something which is proven. And there was no significant difference in the time to progression or in overall survival in both the arms. However, the study was not powered for survival analysis. Both acute and late neurotoxicity and pulmonary toxicity was worse in patients receiving 4 BEP, and there was no difference in hematologic toxicities. So after this cycle, they concluded that 4 BEP is better than 4 EP. However, the toxicity is more. So in this study, the JETOC T93 BP study, they tried comparing 3 cycles of EP versus 4 cycles of EP. It was a phase 3 randomized controlled trial in 28 centers, and they included 270 patients. And they included most non-seminomatous germ-cell tumor, which was metastatic, good risk, according to the Institute Gustave-Roussy prognostic model, which was later retrospectively classified as per IGCCG model. And the patients with pure seminoma, no proof of metastatic disease, second primary tumor, and poor prognostic factors were excluded from the study. The primary endpoint was response rates, and the secondary endpoint was event-free survival and overall survival. And they randomized the patients into 2 groups, either 3 cycles of BEP or 4 cycles of EP. Bleomycin 30 international units on day 1, day 8, day 50, etoposide 100 milligram per meter square day 1 to day 5, and cisplatin 20 milligram per meter square day 1 to day 5. And 4 cycles of EP had same doses, just bleomycin was omitted. At the end of chemotherapy, surgical resection was advised for all residual suprasenterometric masses in both arms, as well as delivery of 2 cycles of VIP if viable cancer cells were found in the biopsy report. So the median follow-up was 52.7 months, And after they retrospectively classified the patients by IGCTS classification, they had to exclude 6 patients because most of 6 they had either visceral mets or the LDH levels were high, which was not a criteria for Gustav model, and they included those patients in good risk only. So 135 patients received BEP and 135 patients received EP 4 cycles, and 131 of the 135 in BEP were evaluable, and 126 out of 4 EP were evaluable for response. What they found out was in patients with 3 BEP and 4 EP, the response rate, the favorable response rate was equal in both arms, 95 to 97%. However, when they compared good risk IGCTS prognostic patients in 3 BEP versus 4 EP, what they found was the event-free survival of BEP was 93% as compared to 86% in patients who received 4 EP. Also, the 4-year overall survival is 97% in 3 BP as compared to 4 EP, which had 93%. So there was a numerical advantage in patients of 3 BEP in terms of event-free survival and also in terms of response rate and overall survival. This is just the graph showing the two. However, the study was not planned for measuring overall survival and coming to toxicity in this study. So as we can see, 47% of the patients in BEP group had grade 3, grade 4 hematological toxicities, whereas 62% patients of EP group had grade 3, grade 4 neutropenia, which was statistically significant. Also, they had mentioned that 7% of the patients as compared to 2% of the patients in BEP group had more neurotoxicity, and dermatological toxicity was more in Bleomycin group as compared to EP group, and pulmonary toxicity was also more. However, only 1 patient of the 15 patients in Bleomycin group had grade 3 toxicity. Similarly, patients in the group of neurologic toxicity and dermatological toxicity, even though they were numerically higher, most of the patients had grade 1 and grade 2 toxicity as compared to grade 3 toxicity. So even if the numerical higher rate of toxicity is present for these categories, most of the toxicities were easily manageable and grade 1 and grade 2. This was another, this trial evaluated 835 patients who received Bleomycin, and they predicted the risk for Bleomycin-induced lung toxicity in patients with germ-cell tumor. So 835 patients were prospectively studied, and 6.8% of the patients had Bleomycin pulmonary toxicity ranging from X-ray or CT changes to dyspnea. There were 1% patients who died due to Bleomycin pulmonary toxicity. The median time from start of Bleomycin administration to documented lung toxicity was 4.2 months. And on multivariate analysis, factors independently predicting for increased risk of Bleomycin pulmonary toxicity was low GFR, age more than 40, and stage 4 at presentation, and cumulative dose of Bleomycin more than 300. So just to conclude, what we have seen till now is BEP has slightly better response rate as compared to EP group. They probably have a better survival, though there are no direct head-to-head comparison between overall survival in EP and BEP group. They definitely have a better side effect profile because hematological toxicities are more in 4 cycles of EP as compared to 3 cycles of BEP, and other toxicities are low grade in terms of Bleomycin-induced toxicities. They definitely have a better quality of life, as we saw difference between 3 BEP and 3 cycles of BP and 1 EP. Also, in our scenario, there is less burden on daycare, which is more important because giving 3 cycles and completing the treatment is much better for them as compared to 4 cycles. And we also use 4 cycles of BEP in patients with poor risk germ-cell tumors. So, omitting Bleomycin in a good risk patient, whereas giving 4 cycles of Bleomycin in poor risk patients. So when we see poor risk patient, we tend to give Bleomycin, even though we know that there will be toxicity because we want good response rate. Similarly, in patients of good risk, giving 3 Bleomycin, Etoposide, Cisplatin would be a better regimen as compared to etoposide cisplatin. Thank you.
Thanks, Pritesh. Rahul?
Yes, sir.
Start now.
Good morning, respected teachers and dear colleagues. I will be continuing the debate and I will be presenting for EP, 4 cycles in a good risk germ-cell tumors. Now, before we go further, if we see the development of the regimes like EP, EP is basically developed by the MSK-CC group, where they compared EP 4 cycles to at that time standard regime for MSK, the 5 drug regime Web6. In that comparison, they have shown that the use of EP has produced almost similar CR rates as compared to this 5 drug regimes. This 5 drug regime has Bleomycin, and in that study they have shown that the 16% cases required removal of Bleomycin from therapy due to a decrease in diffusion capacity of carbon monoxide and or the vital capacity. If you see the development of BEP regime, it was developed by the Indiana University and the Southeastern Cancer Study Group. They somewhat use a different prognostic method where they divided the patient in minimal, moderate, and advanced stages of germ-cell tumor, and the good risk patient were usually the minimal and moderate group patients. Even in this condition, they have shown that the BEP regime 4 cycle versus BEP versus 3 cycles has produced similar response rates. If you compare the results of 2 different studies, that study have shown that if we use EP with 6 cycle of Web at a median follow-up of 25.9 months, there is no difference with Web6. And the similar results with BEP3 and BEP4 has shown that there is no difference at the median follow-up of 19 months. For both the studies, there are long-term data has come around 10 years data has been come, and in both the studies, the 10 years response rates are quite similar, even if you are using the BEP3 cycles or EP4 cycles. Now, if we continue the discussion on development of the regimes, initially the Cisplatin, Vinblastine, and Bleomycin was the standard care at Indiana University in 1974. And then it was considered 4 cycles PVP followed by 21 months of maintenance Vinblastine. Later studies suggested that maintenance Vinblastine is not necessary, so they cut off the Vinblastine, and the standard regime at that time was PVP. Then in 1981 to 1984, the Southeastern Cancer Society Group phase 3 trial compared 4 courses of PVP with 4 cycles of Cisplatin, Etoposide, and Bleomycin, which has produced a similar result. The response rate of the survival of entire patient population was superior but not statistically significant for PVP16 B. I mean, this will be Cisplatin, Etoposide, and Bleomycin now. So the results were similar. This chemotherapy regimens, including high dose of Cisplatin, followed by adjuvant followed by post chemotherapy RPL-NDS resection, has of apparent residual disease will cure 70 to 80% patients with advanced germ-cell tumor of testicular and extragonadal origin. At the same time, there were data which has shown that those patients who has not responded to this chemotherapy, if we use Etoposide, it has a very good activity. It has so great activity that it is considered second most active drug in GCT after Cisplatin. And a review of Etoposide Cisplatin based salvage chemotherapy data showed that a proportion of patients with disease resistant to regimens, which include Vinblastine, Bleomycin, and Cisplatin, are cured with treatment based on EP. Treatment that can cure in the salvage setting, despite the use of doses of Cisplatin equivalent to those used during initial treatment, would be expected to be highly active in previously untreated patients. And because of this, the Etoposide Cisplatin regime is moved forward in the curative setting also. Now, what is the criticism of Bleomycin? If you see the ERTC study, which was done by Stotter et al., it has contained 180 good risk patients with lymph node metastasis less than 5 cm, lung mets less than 2 cm, and AFP value less than 1000 and HCG less than 10,000. This study compared BEP with EP, and CR rates were 95.5% versus 95.2% respectively, so almost similar. There was no difference in continuous DFS, 94% versus 92%. Those treated without bleomycin did not suffer lung toxicity or significant skin toxicity. And strikingly, the BEP was found to have more myelosuppression than EP. After this study, there was another study which is Australian group, and they compared PVB with PV. So basically, they compared cisplatin, vinblastine, bleomycin to cisplatin and vinblastine without bleomycin. So this study included 104 patients of good prognosis, testicular cancer, and then again there was no significant difference in the response rate. So the value of bleomycin during initial therapy in the GCT was questioned with these data. Then from 1981 to 1984, the Southeastern Cancer Society Group phase 3 trial compared 4 courses of cisplatin etoposide plus bleomycin, and it has shown that use of bleomycin is associated with around 1.9% mortality. If we follow the current IGCC recommendation, and if we see the trials which has been mentioned by the IGCC in their current paper, there is only one trial which has compared EP to BEP, that is, which is discussed by Pritesh also, the GCT trial. And if we see the response rate, the complete response rate is around 92 versus 91%, which is almost similar again. This is the original article which we are discussing, the GCT study. This is the trial profile, 135 patients in each arm and 127 alive at last follow-up in the BEP arm and 118 in the EP arm. The study characteristics already discussed by Pritesh. Now, if we see the efficacy and the survival, one of the important thing is that primary endpoint of this study was favorable response. So what is favorable response? Favorable response is basically when the patient is achieved complete response. So there is no visible tumor or no evidence of any tumor, that is CR. Then there is pathological CR. Pathological CR is when the patient, after completing chemotherapy, underwent surgery, but in the HPR there is no viable tumor tissue. Then there is PR, and then there is serum, marker CR, when there is no tumor marker is available and there is no tissue available, no tumor tissue is present. And then there is PR. So CRs and PRs considered favorable response. And if we see the CR and PR rate, it is similar with BEP, 3 BEP versus 4 EP, with a P score of 0.34. Incomplete response rate is almost similar. If we see the 4-year event-free survival with 3 BEP, it is around 91%, and if with 4 EP, it is around 86%. Numerically, the event-free survival is superior, but we also need to understand that that GCT trial initially included a patient on the risk profile based on risk profile they used at their center. Later on, after completion of trial, they retrospectively divided the patient to good risk, intermediate risk, and poor risk based on the IGCC criteria. So this is something which is not pre-planned. This is something which was done after completion of study. So we can't be sure with the numerical values. Similarly, the 4-year overall survival is 96% versus 92%. Again, very much similar. This is the event-free survival and overall survival of the study. Now, if you see the surgery in this group, surgical resection of residual masses at the end of chemotherapy was carried out in 51% and 52% patient of 3 BEP and 4 EP. So almost similar surgical resection rate in each arm. Median time to surgery after completion of chemotherapy was 8 weeks in each arm. 48% and 46% had abdominal surgery. 7% and 13% had thoracic surgery. And around 5% in each arm had both surgery. So even the resection rate in each arm is similar. Toxicity, strikingly, the grade 3 and 4 neutropenia were higher in EP arm, though same dose of EP is used in both the both BEP and EP has slightly higher doses of etoposide, and cisplatin, which gives us an idea why there is high myelosuppression. But again, the FN rate, the febrile neutropenia rate, is similar. Statistically, no difference between EP and BEP. Almost all other toxicities were equal in each of the arm. Now, one of the important thing is dermatological toxicity. If we see more than grade 1 dermatological toxicity, this was more common with bleomycin, which bleomycin containing arm, 16% versus 3%. Now, what are the drawbacks of this study? As we already discussed, that the event-free survival, patient who achieved CR to chemotherapy plus surgery. So when they are discussing the event-free survival, what they did, that they included the patient who achieved CR to chemotherapy plus surgery. Surgery means complete resection of viable germ-cell tumor in residual masses after chemotherapy, and patient who relapsed with mature teratoma. So these two classes they considered as event associated with treatment failure. So this, the patient who received complete chemotherapy and they underwent surgery, and even if there is no tumor seen, or even if there is immature teratoma, they consider that as event, they consider that as a treatment failure, which is not right. Similarly, statistically, this study is underpowered to either detect superiority or establish non-inferiority, and multiple endpoints were tested. So, which makes a higher rate of false positive conclusions. Now, though there is very limited long-term complication which has been shown by this study, but we know that the bleomycin toxicity is very important, is a very important consideration, especially in good risk patient who, in any case, will survive longer. Now, if you see the 4 cycles of EP, it is well tolerated and it avoids all bleomycin-related toxicities. Acute pulmonary toxicity is reduced with BEP into 3 cycles, but it may contribute to morbidity in post-chemotherapy resection with rare post-surgical deaths. And to understand the long-term complication, if we see the effect of bleomycin administration on the patient of pulmonary toxicity in patient with metastatic germ cell tumor receiving first-line chemotherapy, there is a meta-analysis. This meta-analysis shows that there is a pooled probability of all grade pulmonary toxicity in the bleomycin and bleomycin arm was 11.7% and 1.7%. So the toxicity rate is 11.7% for bleomycin containing regimes, while it is 1.7% for those who are not receiving bleomycin. Grade 3-4 pulmonary toxicity, if you see the grade 3-4 pulmonary toxicity, there is the risk is 4.1% higher for bleomycin containing regimes. So obviously, avoiding bleomycin would be so avoiding a long-term complication would be our priority for these patients who will in any case survive a very long term. So to conclude my points, EP 4 cycle has produced similar outcomes in comparison to BEP 4 cycles. Toxicity profile of EP is much better than BEP. A properly powered randomized trial comparing the efficacy and toxicity of BEP 3 cycle versus EP 4 cycle will likely never be conducted because it will require a very large sample size, which would be the main prohibition for doing this. And until prospective clinical trial, both regimes will remain first line option for good risk GCT patient. And I would like to say that because of better toxicity profile, using EP would be much more better for good risk patient of germ cell tumor. Thank you. Sir.
Pritesh, do you want to have again some debate on this Rahul's presentation?
So we
have 5 to 10 minutes.
Yes, sir. So first thing, even though that the JETAC trial showed that the complete response rates, which was the primary endpoint, was similar in both arms, we have to also consider that we are giving 500 milligrams of more etoposide and 100 milligrams of more cisplatin in the EP group, and their cumulative toxicity should be included in terms of long-term survival also. Also, the meta-analysis which showed 11% risk of bleomycin associated toxicity, it also mentioned that most of the toxicities was early stage. So if we are in a tertiary center where we can say detect early pulmonary toxicity, that could be prevented. And giving 3 cycles is better because one, you are completing the treatment earlier as compared to 4 cycles, which will take at least a month more. And even though we don't know whether the survival will be better in which of the arms, unless we have a prospective clinical trial, I would suggest if we can detect bleomycin toxicity early, if we can complete the treatment early, and if the quality of life of the patient is better in terms of 3 cycles of BEP, we should consider BEP as compared to EP.
So, sir, can I answer?
Yes, Rahul.
Yes. So the thing is, when we are saying that bleomycin will improve quality of life, we also need to understand that the patient has to go repeatedly for other tests, bleomycin related tests like PFT, DLCO. There is chances, though it is grade 1 or grade 2 lung toxicity, but there is very high chances that in later life he will have complication with this lung toxicities. There is one more thing which I also want to mention, that using bleomycin BEP regime has produced very high risk of cardiovascular complications, Raynaud's phenomena. And there is a paper which has shown that only those patients who used bleomycin along with cisplatin has developed this Raynaud's phenomena and cardiovascular complication. So yes, we are giving less dose in 3-cycle BEP, but we also need to understand that the addition of EP has produced toxicity which are mainly myelosuppression and which has been managed, which are acute and which has been managed. There is no long-term complication of addition of 1 cycle of EP, but there is long-term complication of addition of bleomycin. So for these kind of patients who will survive around, whose 10-year survival is in the range of 93-95%, we would like to have a less and less long-term complications and a better quality of life. So, I mean, in that sense, I would prefer EP 4 cycles. Sir?
Hello. Anyone have any questions? Mr. You have any opinion on today's debate?
So I think there is no one answer to this question, whether the 4 EP is better or 3 BP is better. So both are, the most important thing is that both regimes are more or less have produced similar results. We have to choose our patient wisely or carefully. So like the Pritesh has mentioned about the 3 BP, the toxicity of bleomycin, we all know that it's around 8 to 10% and about 1% fatality. So that is some concern. But if you choose your patient correctly, follow them properly, this the bleomycin toxicity at least can be avoided. So like a patients in the Royal Marsden data, they have chosen the cutoff which we have in their paper, that is age more than 40 year patient with a GFR less than 80, previous history of smoking. So all these patients group which are at high risk of developing complication, if you can avoid, and other thing is that patient with a high volume lung metastatic disease, in those group of the patient, the bleo can be avoided and 4 EP can be given in those group of the patient. But in a patient who is otherwise fit, normal lung function, normal renal function, young patient, the overall literature of the data suggests that 3 BP is the standard compared to the 4 BP. So it is the question of a long-term toxicity of a etoposide cisplatin vis-a-vis the toxicity of a bleomycin. So in my opinion, I feel that if we can avoid the bleotoxicity, choose patient wisely, 3 BP is the standard. But in patients where the risk factor are high, we know that the patient may end up in a complication of bleo related. In those scenario, 4 EP is the. So both regimes have their place, but in a selected and properly chosen patient. So if any patient of a 45-year male comes with a good risk patient, will I like to use a 3 BP? No, in those group of the patient, we may go ahead with 4 cycle of EP. Patient having a multiple metastatic lung lesion with tumor marker still in S1 range. Do you want to go ahead with 4 BP? No, in those group, we may go ahead with 4 EP. But in a 25-year-old male, no smoking history, absolutely fit, do we want to consider 4 EP? No, in those group of patients, we may go ahead with 3 BP. So at the end, both our regime are equal results. They have the patient needs to be selected for that regime, and superiority of one over other has not been demonstrated in terms of the selected patient criteria. So both regime can be considered in a properly selected patient.
Sir, I have one question. Hello?
Yes.
So, sir, I mean, yes, this is something which we have derived, that when to use EP, when to use BEP. But in non-selected population where this trial has been done like this, two differently done, I mean, there also they have produced quite a good results. I mean, EP and BEP. So why we want to add Bleomycin? I mean, if we go with the long-term outcomes, around 10-year outcome has been come. Addition of EP has not produced so much of additional side effects in comparison to 3 BEPs. So why we want to add Bleomycin for even for fit patients?
So I think the most important question, the answer for this question is that why you want to add additional Etoposide with additional Cisplatin in this group of the patient. And definitely the although the practical risk is not, but the theoretical risk of Etoposide in long-term complication of a secondary leukemia and Cisplatin related complication is definitely there. So why to expose the patient when we want to, at least in testicular cancer, good risk patient, the long-term. So the same question in an indirect way for like a Hodgkin lymphoma, or where the survival is improving over due course of time. Why we want to reduce the dosage or cut down, like in ALL and all that, the overall chemotherapy regime, they are trying to omit the ADRIA, they are trying to like in stage 1A Hodgkin lymphoma, good without any B symptom, 2 cycle of ABVD is good enough if there is a pair. So ultimately, we don't know about the long-term complication of these Cisplatin and Etoposide. From that point of view, exposing the patient to a additional Cisplatin of 100 mg and then Etoposide of 500 mg, when we know that patient is already at 2 to 3% risk of developing secondary leukemia, that is the region. But if patient having some issue with the use of Bleomycin, then it can be used. So there is no right or wrong in 4 EP versus 3 BP. You have to choose your patient widely. But whatever the literature or any international experts or guideline, if you say in a young fit patient, whether the 3 BP is to be used, or they have not concluded that 3 BP is better, which one is preferred. So ultimately, in a young fit patient, 3 BP will be preferred over 4 EP. So it's the complication, long-term unknown complication, which we don't know, and literature says that definitely as the dose of, and if you see the cumulative dose of Etoposide and the secondary leukemia risk is started gradually increasing rapidly as the cumulative dose increases. And in unfortunate scenario, when you have to use, if there is a risk recurrences, again, some regime contains the Etoposide, which may be from the secondary point of view can be one region to avoid additional Cisplatin and Etoposide. And the other thing is, which Pritesh mentioned, in this kind of overall time from the health infrastructure and the patient remains in the healthcare setup for a longer period of utilizing resources for a longer period of time. When we have an equal result with 3 BP, why to give him one more cycle? But definitely not in all patients BP can be chosen. So you have to select the patient for BP. You cannot use in all patients the bleomycin. In those groups of patients, EP is as good as. But whatever the literature says that in a young fit patient, no contraindication for the bleomycin, can we use 4 EP or 3 BP? I will say that 3 BP will be the preferred choice. Ajay, take further.
Thank you so much, sir.
What's your opinion? I think you can also have some.
Yes, sir. I'll give the final conclusion. Anyone else having any opinion or any doubt?
Ajay, may I speak?
Yes, sir.
Yeah, so to add, Amit sir, so I think this question of EP versus BP and why EP is not the default, because the long-term outcomes are good without any toxicity. So I think this correlates well with the Hodgkin studies that has been done. So, it depends on which regimen evolved first and how you compared it. So BP is a tribute to Dr. Einhorn from Indiana University. So EP developed later on from MSKCC. So this JETUG study that you have discussed, the French study which have compared BP versus EP, I think that is the best, the right dosing of EP they have used. And still you see that there is a difference in terms of event-free survival between BP and EP on the long run, though it was not statistically significant. And doing hard endpoints of EFS with the phase 3 RCT, the number of patient number increased phenomenally. So all these studies have been done based on endpoints like response rates. But though that study didn't show a statistically significant difference, but still there is a numerical difference between BP versus EP in the long run, the French study. I think that may be the reason getting away with bleomycin and just implementing EP is something which will be difficult. But in a given situation, as sir said, that you have to choose judiciously based on the age and comorbidity. Similarly, if you see Hodgkin, we choose 6 ABVD, but still we are not going to avoid bleo. So we are looking at options of how to avoid bleo in Hodgkin. So now after 2 cycles, if patient is PET negative, we are avoiding bleo. Now we know that 2 cycles of bleo is something which is definitely needed. Earlier we used to give 6 cycles of bleo. So that's how the evolution will happen, but the de facto standard will remain the kind of regimen that was evolved previously.
I mean, I have answered this question, that why there is a numerical difference for event-free survival. But what they did when they calculated the event-free survival, they included those patients who, after completion of chemotherapy, underwent surgery and there is no pathological tissue present, but still they consider that as treatment failure. Similarly, those who had immature teratoma also considered as treatment failure. So I mean that data is something which is not right, because technically they are disease free, but they have underwent surgery due to some reason. And resection rate in any case, both sides are similar. So I mean, that point does not prove that, being numerically different does not prove that one is superior, one is inferior. And second, sir, for Hodgkin's lymphoma, now we have that the PET has proven that there is no tumor left, so we are cutting on bleomycin, but we don't have such algorithm in this this particular group of patients. So I mean, how to assess, I don't know why EP is not superior, why EP is not superior. So that is question, that something remains again.
Sir, I think Jaya here, hello.
Yes ma'am. Yes ma'am.
No, I just wanted to also ask, or any thoughts on the fact that, whether there was any difference, have they done it histology wise, like say something for a yolk sac tumor versus a dysgeminoma and their aggressiveness. So I was just wondering whether in the JETUG paper, whether there was a difference based on histology. Any such thoughts, or Amit, any thought on that anywhere? Because that was some question that I had.
I often not remember, because whatever the decision making in a good risk patient, the histopathology doesn't in the risk staging of a IGCC, the histopathology doesn't come into the picture. But because that takes the only the post orchidectomy tumor markers and the location of the primary tumor. So exact histopathology, I don't remember. I have to see whether they have, but I don't remember that any study has analyzed the subset, even subset analysis as per the histopathology in the primary. We have to look into that. But the only thing is that if there is a more component of mature teratoma, the response of the chemotherapy might be less. But for rest other component like yolk sac, embryonal or choriocarcinoma, there is such no data that one regime has a better
So
response rate.
basically what I was thinking is like a dysgeminoma versus a yolk sac, so something like that. But yeah, I know there is not much data with regard to that. And another thing is like, I mean, not for this group, but for like advanced stages, although in ovarian germ cell, there are no randomized trials, but now instead of 4 BEP, they use 3 BEP and 1 EP for like advanced, I mean, there's some data or some thought to move away. So I thought that any inputs from your, from the male germ cell, so that.
Yes, so for the poor and intermediate risk, some center uses this because the cumulative dose, I think it comes down to less than 300 if we use 3 BP followed by 1 EP. So some center are still practicing, but what the volume of a tumor, what we see here, the tumor marker and the we are continuing with because the volume of the tumor and the tumor markers level, what we see in our setup is far different. So their poor risk and our poor risk are little bit different. So we generally continue with 4 cycle of BP in poor and intermediate. We don't avoid. Generally repeat a PFT DLCO say after 2 cycle, and if everything is normal, we go ahead with the 4. But definitely there is one subset of paper which looked into this aspect of 3 BP followed by 1 EP, and which has more or less same results. So some center are practicing this of 3 BP followed by 1 EP in poor and intermediate risk patients. Ajay?
Dr. Manju has, I think.
Ajay, are you there?
Yes, sir, I'm here. Manju madam has given comment.
No. So, I just added something which I just fetched looking at the discussion going on. So this is again a retrospective analysis from their own database. And this is a 10-year OS difference where, there's almost 3 times, but, the numbers were small. So it's not statistically significant difference between BP and 4 EP. And the concern is that, the cumulative dose in the EP4 is much higher as compared to 3 BEP. And therefore, there is always a risk. I mean, this falls into the medium dose etoposide, so higher chances of developing therapy-related MDS/AML later on. So that would be a concern. So, and in addition to what Amit said, that, if somebody is staying back for 4 courses of EP, you're adding the risk of toxicity as well as longer duration of stay near in the vicinity of healthcare facility, more healthcare resource utilization. And if there is no definite evidence, I'm not sure whether 4 EP is considered superior, except in select circumstances where you find difficult to use Bleo.
Yes, ma'am. So now it's 9:26. So we'll come to the conclusion. So I think both the Rahul and Pritesh has did very good job, with some advantage to Rahul being more aggressive. And now I'm convinced, as per the guideline, both are recommended option. But looking at the data, with some advantage for Bleomycin in terms of reduction of event-free survival and relapse, the BPs, 3 cycle BP and the duration of therapy and patient's choice, and I think also at our center the resources. So maybe 3 cycle BP will be favorable as opposed to the 4 cycle. But in terms of results, I think 4 cycle EP is also equivalent. So typically we need to see the scenario, and we need to choose the patients very selectively, as Amit sir said, to see the contraindication for Bleomycin. and keeping in mind the long-term toxicity of cumulative extra cycle of EP, we may favor BEP over 4 cycles of EP. But as of now, there is enough data to suggest the outcome with the either a 3-cycle BEP and 4-cycle EP is equivalent. So I think at our center here, because of patient resources and time limit, we may favor BEP. But whenever there is a contraindication to bleomycin, we can consider going ahead with the 4 cycles EP. And with this, we will conclude with the today's session.